Okay. Well, thank you everyone for joining. It's fantastic to be here today and to introduce my friend Ijeoma Ekeruo, talking about updates in management of acute atrial fibrillation, all a primary care provider would like to know. So we're very interested to hear about updates in AFib, and Ijeoma, if you want to take it from here.
Well, thank you so much. I was thinking to myself, I should have brought some water and I didn't. So I apologize for the quality of my voice in advance. Basically, thank you for having me come to speak on this very important topic. Um, we have been going to or performing skill sharing trips and, helping take care of patients in sub-Saharan Africa for a few years now. And, over the last couple of years, particularly in West Africa, we've concentrated on, having patients be referred for ablation procedures. And outside of WPW, one of the more common arrhythmias that we're seeing is atrial fibrillation. Now, the idea or the theory has been that, amongst people of African descent, there really isn't that much atrial fibrillation. We do need definitely to have a lot of data, which we do not have presently, which is as a result of, lack of resources. A lot of patients or a lot of people are not going to physicians who are necessarily getting an EKG. Atrial fibrillation at times, about 50% of the time, can be asymptomatic. And so a lot of patients can come in and it's just an incidental finding. Um, but we definitely, need to get a little bit more data about what the incidence is, particularly in the countries that we visit. And so we're hoping that we can do that in the near future. But to start that off, what first needs to happen is that we need to recognize what atrial fibrillation is. So that's part of the reason why I decided to, when they asked if I wanted to do a deeper dive into atrial fibrillation, I just thought that this would be a good topic. So there are a few things that we're going to talk about. We have discussed atrial fibrillation in this forum before, and we do it almost every year when we're in the Nigerian Cardiovascular Symposium. But this is going to be a little bit more in depth. There are some slides that you might have seen before, but I'll be talking about it a little bit more. And so if some folks want to ask some questions, this is definitely meant to be interactive. If you have any questions, concerns, or anything that you want to ask, please raise your hand and we will give you the ability to speak. Or if you happen to be on the panelist panel, then you can unmute and speak yourself. So over the course of this discussion, I want to discuss, the pathophysiology contributing to the development of atrial fibrillation, understand how our treatment and management of atrial fibrillation can differ depending on whether this is considered to be an acute or a chronic presentation, and then basically look at some of the guidelines, which, the United States has some guidelines that they brought out, I think, in 2023. The ESC has some from a little bit, or at least an update within the last year. And so this will definitely help us kind of look to the different ways that we've been looking at atrial fibrillation and what we can do to help manage it. So it's not uncommon that a patient, presents like this, where, they come in, and you hope they come in with complaints of palpitations. A lot more times they say, hey, I have some shortness of breath. I don't really know why. Sometimes they have dizziness. Sometimes they have chest pain. In this particular patient, they felt dizzy, and that's the reason why they came to the emergency department. And they had an EKG that showed an irregular tachycardia. So there are a few things that we want to look at. The first thing is, when you see EKG, is it narrow complex, is it wide complex? If it's a narrow complex, then you want to know, hey, what is the rate, which here you can tell is pretty fast. One of the ways that you can determine what the rate is on an EKG if you do not have a regular rhythm is to count the number of QRSs and multiply that by 6, because each EKG is basically a 10-second snapshot of your heart. So you multiply by 6, and depending on what that is, that will determine if it's tachycardic or not. And then the more important thing, though, you want to figure out what exactly is the rhythm. Now, the thing that determines what the rhythm is the presence or absence of a P wave. So the combination of these two things, whether it's regular, irregular, wide complex, narrow complex, presence of a P wave or not, where that P wave is coming from, all those things kind of tell you, hey, what is this rhythm? And one of my classmates in fellowship basically mentioned, and I've never forgotten this, where somebody said, well, maybe this is atrial sinus rhythm. And he was like, no, this is the opposite of sinus rhythm. So that always made me chuckle a little bit. But pretty much instead of having any synchronized atrial activity, you actually have no synchronized atrial activity. And the reason why that happens is because atrial fibrillation causes a really fast electrical activity in the top chamber of the heart that basically causes the top chamber to just kind of fibrillate. So it doesn't have that synchronized squeezing that we need to have that atrial kick. Instead, you just have the atria just kind of doing something like this, reducing your cardiac output for by about 10%, which is the reason why a lot of times when you have atrial fibrillation, you actually end up being tachycardic. Um, and so if you see an EKG that is irregularly irregular, there's no pattern to the irregularity, and you don't see any P waves, then it's more likely than not that this will be atrial fibrillation. And then you can kind of see on this EKG where you just see these fibrillation waves. Sometimes you don't see anything, you see a straight line if it's so fine. But here we're lucky enough to see fibrillation waves that basically supports the diagnosis of atrial fibrillation. So I'd like to break this down into kind of, I say 10 commandments is not really as strict as a commandment, but I want you to think about these things when you're approaching a patient with AFib. So again, what is atrial fibrillation? You have irregular RR intervals. You have the absence of distinct P waves. Now, you could be tachycardic or not. You could be symptomatic or not, right? So those two things, if you're tachycardic and symptomatic, it's easier for you to diagnose. But because atrial fibrillation can exist without tachycardia or without symptoms, it becomes very difficult to diagnose. What we do know, though, is that it increases mortality and morbidity. That can cause an increase in strokes, or it can cause an increase in heart failure. The relationship between atrial fibrillation and strokes, the presence of strokes or not, really, we're not really sure. We know that 90% of the strokes come from the left atrial appendage, which, if you remember when I said that the top chamber of the heart is just not squeezing that well, and there's no synchronized electrical activity, which can be shown in these pictures here. You just kind of have electrical activity going in different areas in such a way that the top chamber of the heart does not squeeze in synchrony. So when that happens, basically you can have these areas of the heart that don't move as well. You don't have that movement, and that can cause stasis, which in turn can lead to a thrombus in the left atrial appendage. When that happens, it can form a stroke. So that's the mechanical reason for atrial fibrillation causing stroke. The other reason, which is a lot more complex, is that atrial fibrillation might be a sign that there is increased inflammation in the body for whatever reason. And so, if that's the case, then we don't really know if the presence of atrial fibrillation is a cause or an effect, right? So is it a cause of the stroke, or is an effect of the increased inflammation, is just a sign or a symptom that this person is at increased risk for stroke? Either way, if we give the patients anticoagulation, that decreases the risk of stroke, brings it back down to that of, the regular population for that certain age. And that's basically where we go. So how do we diagnose atrial fibrillation? Strictly, if the patient comes in with symptoms, we do a rhythm strip or we get an EKG. And if the EKG says that they have AFib, then boom, the patient has atrial fibrillation. Now, there is, because of the presence of pacemakers, implantable loop recorders, defibrillators that might have an atrial lead, there is the classification of atrial fibrillation being subclinical. So that basically looks at these atrial high rate episodes that basically are shown on, they're shown on your device. And so when you see it on the device, then you have to kind of look at it and say, hey, does this qualify for for it being atrial fibrillation or not? So I'll give you a few examples of why, this is considered to be subclinical, and it does need for somebody to take a look at the EGMs or the electrocardiograms to tell if the patient is in atrial fibrillation. And it also requires for there to be a lead in the top chamber of the heart, because sometimes if there isn't a lead, then you can mistake something irregular, maybe a sinus arrhythmia, for AFib when it actually is not. So, for instance, looking at somebody like this, right? Top chamber is going to be in the atrium. This is the ventricle. And then you can kind of see that in the ventricle is being paced, top chamber. You can kind of see these markings, and you see this AMS here that basically says you're in a mode switch episode, which is basically where the device kind of recognizes that, hey, something is going on in the atrium. We don't know what, so we're just going to ignore it and, kind of just go on with our ventricle. We're not going to follow it. We're not going to treat it like we typically would for a pacemaker. But you can tell whatever is happening in the top chamber of the heart is pretty irregular. It's very fast. And so, when that happens, this is atrial fibrillation. Now, this is another atrial high rate episode, at least that's what the device is telling us. But what you can see here is that on the top chamber, no matter what it says, so this is whatever is happening in the atrial EGM, this is what's happening in the ventricular EGM, but you can kind of see that over here, now the device is calling some things that are not really real, right? So here it says that there's something in the atrial EGM, but that is not anything, right? And unfortunately, it shocked the patient over here because of what it thought, and mainly because it thought that there was also something happening in the ventricle. And so you can kind of see here where you have oversensing, where the device is seeing things that are not real. So if you saw an episode like this, you would not diagnose that patient with atrial fibrillation. How about this? This is a patient with an implantable loop recorder. You can kind of see the EKG over here, and the EKG looks to be pretty, sinus rhythm. But there's certain things that you're seeing there, right? You're seeing oversensing of the T wave here. And whenever you see these train tracks, right, in the EGMs, you can kind of think, okay, there's some oversensing happening here, either P wave or QR or T wave. So here you have T wave oversensing. So it's telling you that this is atrial fibrillation, but of course, when you look at the EKG that it got at the same time, you can kind of say, hey, that's inappropriate. So there are a couple of studies that were done starting from 2017 that basically looked at in patients who have devices. What can we say about the risk of this subclinical atrial fibrillation and the occurrence of stroke? So there were two studies that were done, one that was done in 2017 and the other, I think, 2019 or so. And the first one said, hey, if you saw any episodes of atrial high rate episodes, that actually was a sign that this patient had atrial fibrillation and was at increased risk for stroke. And then when they looked at it further and looked at the different, lengths of time that you're diagnosing these atrial high rate episodes. So they said, okay, if it's less than 6 minutes to 6 hours, 6 hours to 24 hours, and greater than 24 hours, which ones were more likely to result in a stroke? And what they saw is that if you had subclinical atrial fibrillation that was greater than 24 hours, it was associated with an increased risk for stroke. This is unlike regular atrial fibrillation, where just the presence of AFib does, put you at increased risk for stroke. And so all you can say is that if you have these significant atrial high rate episodes, first of all, you have to, litigate that. You have to make sure that it's atrial fibrillation. And then the second thing is look at the length of time. Usually what we say is, hey, if it's greater than 6 hours, most likely. If it's less than that, but definitely greater than 5 minutes, you might want to consider that it is atrial fibrillation. And when that becomes important is for patients who you have not actually seen atrial fibrillation with them. They have no symptoms. You do an EKG, and every time you see an EKG, they have a normal sinus rhythm. Then the question now becomes, hey, because of this thing that I saw, are they really at risk for stroke? Particularly since, bleeding risk for all these medications is not exactly, it's not exactly a benign medication. Um, so there were a couple of studies, that kind of looked a little bit further into this, where they looked at Eliquis or Pixaban for stroke prevention. This was the Artesia trial. This basically shows that in patients with subclinical atrial fibrillation, the use of Eliquis actually decreased stroke or systemic embolism, right? So this was very good. However, the NOAA study, which was looked at anticoagulation with edoxaban or Savesa for us here, I don't know what it might be called internationally, but in those patients, when they looked at a composite of cardiovascular death, stroke, or systemic embolism, they didn't really see a difference. Because the study was not powered for just stroke, you can't really look at the results and say whether it would have been the same if the endpoint had been the same for the other study, which is, unfortunately, some of the risks that we take when you do, device studies without the best statistical analysis pre. And so who knows, probably in the next couple of years, once they get enough information or enough patients, they might be able to kind of give us a little bit more information. But, that was a real shortage of the study where they didn't actually power it high enough so that they could tell the difference with stroke by itself. So, what are the recommendations for oral anticoagulation for patients with device-detected atrial high rate episodes? It's a 2A indication if you have one that is greater than 24 hours and you have a CHA2DS2-VASc score that's greater than or equal to 2, right? 2B if it's between 5 minutes and 24 hours, and if it is less than 5 minutes. So if you see somebody, they have this episode, but it's less than 5 minutes, and the device is very, very good at giving you the time. So if it's less than 5 minutes, then there's no real reason for you to give anticoagulation. And at this point, you're required not to. And I do want to make mention that it's a 2B for device-related atrial high rate episodes lasting between 5 minutes and 24 hours. If there's a CHA2DS2-VASc score of 3, versus if it's greater than 24 hours, then the CHA2DS2-VASc score is reduced to 2, and both of them is recommended that you have, anticoagulation for those patients. So if we go back a little bit further, why do we have atrial fibrillation? On some cases, some people say it's because of triggered electrical activity. That's the reason why we ablate in the pulmonary veins, because they're the ones that are responsible for this very high atrial rates. Others say, well, it's more as a result of substrate, right? Which is basically the environment in which any arrhythmia is created. And so what can cause the change in substrate if you have increased atrial pressure? So anything that causes high blood pressure, increased pulmonary pressures like pulmonary hypertension, diabetes is always a good, culprit. Anything that basically causes pressure in the top chambers of the heart can lead you to have atrial fibrillation. And so this kind of came up with, was kind of supported by this diagram by Wise and colleagues, where they looked at, the relationship between paroxysmal and persistent atrial fibrillation, and then permanent atrial fibrillation, which is basically a decision between the physician and the patient that we're not going to try for, we're not going to try for rhythm control anymore. We're just going to give you medications to control the heart rate. But what changes from paroxysmal, where it kind of comes and goes on its own, to persistent when it's there for greater than 7 days? So as you can see here, you have your trigger that is more active in paroxysmal atrial fibrillation. And then once you have enough of a trigger, more time in atrial fibrillation, then basically you actually start to change your substrate. You actually start to change the structure of the atrium. And so, whereas previously we used to be kind of a little bit lackadaisical about whether we converted a patient or put a patient back into sinus rhythm, the more we know about atrial fibrillation, the more we realize that atrial fibrillation begets atrial fibrillation. And so if you want the patient to not be in atrial fibrillation, you have to be very aggressive of converting the patient out of it. And that's as a result of the change from trigger initiation to substrate maintenance. So going a little bit further, do you want to do rate control or rhythm control, right? So rate control is basically where you just kind of control the heart rate. We're looking at use of beta blockers, calcium channel blockers, digoxin, and then in very rare cases, an AV node ablation and placement of a pacemaker. And this is basically where we cut off that connection between the top and the bottom chamber of the heart, but we make the patient pacemaker dependent, and then we put in a pacemaker. The risks of doing that, there are risks and benefits. The benefit of doing that is if the patient does have, heart failure as a result of atrial fibrillation, this can actually correct that because you control the heart rhythm, or the heart rate. Now, rhythm control can be because of use of medications. So your class 1 to 4 medications, your flecainide, sotalol, dofetilide, ibutylide, which are the dofetilides, ibutilides, and a little bit more dangerous. They can increase your risk for cardiac arrest and torsade de pointes. And then, of course, there's amiodarone, everybody's favorite medication. Not really, because 10% of patients will end up having problems. And then, of course, there's ablation, which is definitely very capital intensive, but it has been the most successful for rhythm control in patients with atrial fibrillation. I would say that in patients who have AFib, I would say about 20 to 30% of those patients are getting ablated. So even still in the United States, and maybe in other places, it's not as widespread as it should be, and we definitely need to spread the word. With regards to um, oh, yeah, somebody was saying that there's always a sense of difficulty for junior colleagues to control the rhythm besides amiodarone usage. And yes, that's true. And that's mainly because by the time the patients come to the hospital, they've actually been in atrial fibrillation for quite a while, unfortunately. And so that's where, us as cardiologists, should do a little bit better in educating our primary care, or those patients or those physicians that are seeing the patients first. We should do better about saying, hey, this atrial fibrillation, even though the patients are not symptomatic, we should do better about converting them back into a normal rhythm. And so, unfortunately, there are limitations to treatment of atrial fibrillation for rhythm control. So amio and flecainide, I wouldn't do that. Sotalol or ibutylide, eh. So the way that I typically will take care of a patient, if the patient says, you know what, I don't want an ablation, I would usually cardiovert the patient. 2 weeks after that, you do an echocardiogram. You try to see what's happening with the atria, what size the atria are, because that will definitely tell you what to do. It is not unusual that if a patient comes in persistent atrial fibrillation, that the first medication I give them is amiodarone. And that's because I want to make sure that they just kind of stay in atrial fibrillation at least for 2 weeks while we try to figure things out. And of course, while we're doing that, we're giving them, trying to figure out if they have um, any thyroid issues, if they have any lung issues. And so we're doing, checking a TSH, doing a free T4, doing a chest X-ray. just to kind of take a look and see what's going on. Following that, depending on what the echo shows about a month or two later, that will determine what medications that we give. If this person decides, hey, they're going to just be medical management. So if the structure of the heart actually looks okay, then I'll start off with the class 1A medications, which include flecainide, or propafenone. If the flecainide fails, then you can always do sotalol. I try not to do dofetilide, and the reason why, unless the patient already has an ICD, and the reason why is because, sotalol, well, dofetilide actually that is the one medication that I have seen that will cause somebody to go into torsade de pointe. Is there a role for magnesium in AFib with RVR? Well, if the patient's magnesium is low, yes, definitely give them magnesium, but it's not like a treatment mechanism. And then for the long-term complications of amiodarone, if you have somebody who is on amio, the main things that you have to do, number one, you have to see the patient every 6 months. You have to check labs every 6 months. The labs that you're checking, you're making sure that they don't have any liver problems, they don't have any thyroid problems. And, looking at those two, you can check an amiodarone level, but most of the time that doesn't really matter anyway. And you also want to do a chest x-ray at least once a year. And then in addition to that, you also want to do pulmonary function tests at least once a year. Now, every medication has something that you have to do for it. So if anybody is on any antiarrhythmic medications, you definitely do want to follow it up with, a treatment plan. So for flecainide, those patients who have a low ejection fraction cannot be on flecainide if you have structural heart disease. For sotalol, you're looking at, for flecainide, also if they have renal abnormalities, you don't want to do anything there. If they're on sotalol, you definitely want to make sure that they don't have any kidney or liver issues. Those are the two main things that you're looking at. And then you're looking at their EKG as well to make sure that their QT interval hasn't prolonged. Because if it has prolonged, that increases the reason for a prolonged QT, which can increase the chances of them going into VT. And so, it would be bad for you to kind of treat atrial fibrillation, but increase their risk of cardiac arrest. That would be terrible. And so let's see. On the ablation, the maximum LA size. So typically when we're looking at the LA size, we usually use the left atrial dimension, which is an old dimension. We have left atrial volumes now, but you'd be surprised as long as your catheter can get to the other side with use of what we call like a medium catheter, then you should be okay. And there's a fair amount of success, fair amount, which means about 75% with 70 to 75% with one ablation, 85% or so with two ablations, and then it can go up to about 90% with three ablations. The highest that I have gone to is about 5.8, but I'm very aggressive about trying to ablate the patients much earlier, just because once the patients have gone from paroxysmal to persistent, that's usually when I'm kind of seeing them every like 3 months and saying, hey, you need to get an ablation, you need to get an ablation. But if they're paroxysmal and the left atrium is starting to get big, like about 4 to 5 centimeters, then I'm also doing the same thing as well. All right, so moving right along, there were a lot of studies, I was on a couple of years ago, this guy was basically saying, oh, what are the 20 studies that internal medicine residents should read in their first year, and then lo and behold, number 12 was the Affirm trial, and after so many EPs complained, he added on this East AF trial, and all of us, kind of look at the Affirm trial like this, basically how one study set AF treatment back a decade. And the reason why is because the Affirm trial that was published in about 2002, the main takeaway point was rate control is equal to rhythm control. There's a lot of details in it, right? So this was pre the ablation era. So there wasn't a lot of ablation. There wasn't even a lot of knowledge of what atrial fibrillation was doing. So we knew that we anticoagulated patients with AFib, but we didn't realize that the risk for stroke in patients with atrial fibrillation was regardless of whether they were in sinus rhythm or AFib. We really thought that it had to do with just the presence of atrial fibrillation. For rhythm control, they did cardioversions as necessary. Most of the time, the patients were on amio. But if you have treated patients with amiodarone, then you know if the patient was symptomatic with atrial fibrillation, most of the time without them with them being on amiodarone, they actually didn't they weren't as symptomatic. So that has been kind of an issue with them trying to figure out whether the patient was in AFib or not, right? So what they ended up finding was that the patients who were on rhythm control medication, mostly amiodarone, they had more PEA, so pulse less electrical activity, more torsade de points when you saw them on rhythm control, and then also more pulmonary events, GI events, bradycardia, prolongation of QT interval. So really, it was a trial of medical management of atrial fibrillation, where you had two different strategies. So it was on one hand, you had antiarrhythmics, and then on the other hand, you had rate control medications. And in that case, right, what they ended up seeing was that, the patients who are on the rhythm control, actually, even though they might have been in sinus rhythm, they did a little bit worse, right? But the other thing and the subtext, which people didn't really kind of emphasize at the time, is that, anticoagulation, regardless, should be continued in this group of high-risk patients. And it led to us doing like the CHAS-VAS scores and all these like the CHAS-2 score and then the CHAS-VAS score. But, for the longest time, when I was in training, everybody would be like, oh, rate control is equal to rhythm control. So we'll just put them on a beta blocker and we'll see how it goes. So there were a couple of trials that were started around 2009, just got published within the last like 5 to 10 years. One of them was the Cabana trial that was basically looking at atrial fibrillation and whether we should do an ablation or we should do drug therapy. And what they found was that for patients who, had an ablation, they actually had superior efficacy. And of course, we're talking about ablation using 3D mapping, doing around the pulmonary veins. It becomes a little bit difficult if you don't have the full, enchilada of tools that you need when you're doing treatment. The other study that was actually published a few years ago was the East AF net for trial, which basically looked at patients, who had, atrial fibrillation diagnosed within a particular time. I think it was within 3 months. And basically they said early rhythm control or just basically usual care. So whatever it is that the physician would end up doing. And what they found was that the patients who had early rhythm control actually did much better, right? And this early rhythm control, it could have been medications, it could have been, amiodarone, and actually AFib ablation was, first of all, it was chosen by the site, but it was much smaller in the, looking at things, right? So here's like 8% of the time. You had dronedarone, aka Multac, that was a little bit more. You had amiodarone, 19%. A lot of people were on flecainide, and then you have propafenone and other antiarrhythmic drugs. And what you end up finding is that over time, those patients who you made it a strategy to, hey, these patients who are in atrial fibrillation, we are going to convert them. This was actually much more superior, so much so that they terminated the study early because it showed so much improvement in cardiovascular outcomes. So at the very least, whether or not you decide to do ablation or whether or not you even have the ability to do an ablation, definitely putting the patients on cardioverting patients, putting the patients on an antiarrhythmic medication, making sure that the patient is in sinus rhythm does much better for the patient. Now, there's sometimes that rate control is a reasonable strategy, if the patient has severe mitral stenosis and, it becomes a little bit more complex. Why? Because with mitral stenosis, you have a change in the left atrial size, a change in the left atrial structure, so much so that it becomes bigger. There's a lot more fibrosis. So doing rhythm control might actually not be possible. You might actually just have to do rate control if you have a severely enlarged left atrium. So to the person that asked the question, what size? Usually if the left atrial dimension is greater than 6, most likely you're not going to be successful even with ablation because there's so many areas, right? And a left atrium is not supposed to be that big. There's a reason why elephants are almost consistently in atrial fibrillation, and that's because, they just have huge atria. There's sometimes you have an elderly patient that is asymptomatic. They're not tachycardic, ejection fraction is normal. When you have a patient who is greater than 80 years old, their risk of being in atrial fibrillation does increase substantially. But if the patient is asymptomatic, then why would we do anything, right? Particularly if they're not going into a rapid ventricular response. So sometimes rate control can be a reasonable strategy. So I don't think it's as complicated, but there's some people who do. Okay. So when do you treat atrial fibrillation? Do you treat it always or do you treat it sometimes? And that is also complicated. The way that you would treat different patients. So if, for instance, this is a patient who's 22 years old, came in after loss of consciousness, EKG showed this. So if you see this, you should immediately be thinking, hey, those QRSs don't look the same. It's irregular, it's atrial fibrillation. I'm worried that this is pre-excitation. This needs to be treated, right? How about this patient, 45-year-old man, febrile, but EKG shows this. Now, if you count this out, this patient is probably about 112, 120 beats a minute. They're febrile, they're short of breath. If you found out that this patient had a pneumonia, then, what you should be thinking about is not necessarily treating the atrial fibrillation. What you should actually be thinking about is basically treating the pneumonia, right? So the atrial fibrillation, yes, you would want to treat it, but that wouldn't be your initial focus. There was a patient that I saw in the ICU once who, they were in a really fast like atrial flutter, and I saw them. The patient was really sick, looked like they had liver disease, hemoglobin was like 7, febrile, abdomen protuberant, and they were like, hey, this patient needs to be cardioverted. I was like, well, you can, but if you do, then this patient might end up actually not going back into atrial flutter or atrial fibrillation. And then what? Like you really should treat whatever the patient came in with. And they were like, yeah, let's just do it. They did it. The patient converted, and 2 seconds later went back into atrial fibrillation with RVR. So in some cases, it's not necessarily the thing to do. So this patient, new diagnosis of atrial fibrillation, has chest tightness and dizziness. Blood pressure is 70/44. Now, if I look at this EKG, the patient doesn't have any ST elevations, and this blood pressure is 70/44. This patient is unstable. So immediately I would shock this patient, right? Versus the other patient who was febrile. And how about this patient who comes in, 88 years old, no known medical history, rate is controlled in clinic for treatment of hypertension? Do we really need to cardiovert this patient? Unless the patient has, I would definitely do an echo to make sure that the ejection fraction is normal. I'll definitely do a Holter to make sure, what is going on over the course of the patient's day. But will I rush to cardiovert this patient? I don't know. How about lone atrial fibrillation? And sometimes you hear about these terms, but there were a few terms that were made obsolete by the last, guidelines. Lone atrial fibrillation, valvular versus non-valvular, just because it was causing a lot of confusion. Really, valvular atrial fibrillation is just atrial fibrillation as a result of mitral stenosis, but people were like, well, what if it's aortic stenosis? What if there's tricuspid regurgitation? Like, which one is valvular, which one is non-valvular? And the reason why that was important is that if you have atrial fibrillation as a result of mitral stenosis, regardless of what the CHA2DS2-VASc score is, you are supposed to anticoagulate, right? So there's a difference in management, whether you called it valvular or non-valvular. So they just kind of took away those terms. And chronic atrial fibrillation, the reason why we took it away is because it doesn't mean anything, right? If the patient has had atrial fibrillation for 20 years, does it matter, right? Or should you be thinking, hey, when they've had it for 20 years, did they have it all the time for 20 years? Or are they having it for 5 minutes for the last every week for the last 20 years? Like, what exactly does chronic atrial fibrillation mean? So instead of that, now we have this classification of atrial fibrillation that should be used by everyone. First diagnosed atrial fibrillation just means, hey, this is the first time that anybody in the medical community for the patient has told the patient, hey, you have atrial fibrillation. This is your diagnosis, because it might be paroxysmal or it might just be this is the first time they presented to you. So first diagnosed atrial fibrillation is the first time the patient ever knows about it, or the first time anybody who's been taking care of the patient knows about it. Paroxysmal atrial fibrillation is AFib that terminates spontaneously with or with intervention within 7 days of onset. Persistent atrial fibrillation is if they were sustained beyond 7 days. Longstanding persistent AFib is if it's greater than 12 months. And remember that permanent atrial fibrillation is a decision that's made between the patient and the physician that, hey, we're not going to try to cardiovert you anymore. We're not going to pursue rhythm control anymore. And no further attempts to restore or maintain sinus rhythm are going to be undertaken. So the reason why I make this very important point is because sometimes patients come in with permanent AFib, and maybe they haven't met electrophysiologists who will basically be like, huh, that atrium actually looks pretty small. I think I'm going to ablate this person. Then all of a sudden the patient's chart says permanent AFib, and then you're seeing the patient later and the patient has normal sinus rhythm. And everybody's like, what happened? Well, it's because that's just a decision that was made. And sometimes the people who make that decision are not necessarily qualified to. And so, certain things can happen. The other thing that happened, over the course of the last guidelines was that, okay, in keeping with what is basically being done now, where you have like different classes of diseases, like we have, stage 1, stage 2, stage 3, stage 4 of heart failure. They did the same thing and the same thing for hypertension. They did the same thing for atrial fibrillation. So for stage 1, they said, oh, hey, anybody who is considered to be at risk for atrial fibrillation. So if you have certain things, like if you are obese, there's a lack of fitness, you have high blood pressure, you drink alcohol, like all of these things that put you at increased risk. Some of them are modifiable, some of them are non-modifiable. So your genetics, your male sex, age, right? That's non-modifiable, no matter how much we might want it to be. But if you are in there, then you are at a stage 1 for atrial fibrillation. Stage 2 is pre-AFib. So basically, if you have any structural electrical changes that make us think, you're probably going to get AFib. This usually is seen either in something objective. So if you have like an EKG that shows atrial enlargement, if you have frequent atrial ectopy, short bursts of atrial tachycardia or atrial flutter, or maybe you have an enlarged atrium on your echocardiogram, that would be considered to be pre-AFib. And why is that important? So those patients should have increased surveillance, because once they go into atrial fibrillation, you want to know about it, particularly if they have a CHAS-VAS score that puts them at greater than a 2% risk per year for stroke. Now, your paroxysmal persistent, longstanding persistent, or post-ablation atrial fibrillation, those are in stage 3. And then your permanent AFib is stage 4. The treatment of all of those ones between stage 3 and stage 4 doesn't really change apart from monitoring for AF burden, which you should stop doing when you're in permanent atrial fibrillation, right? You do just want to make sure when you're in permanent AFib, you still want to make sure the patient doesn't have heart failure. You still want to treat based off of their risk for stroke. And then you also want to treat symptoms if they have any. Now, let's take it a little bit, right? So how about the treatment in an acutely ill patient? For patients who have shock, just the presence of shock can actually increase the chances that they'll go into atrial fibrillation. There are some that say, we haven't done much research into this, but there are some that say if you have shock-related AFib or atrial fibrillation as a result of an acute illnesses that we've seen AFib in, anything that causes you to have hypotension requiring vasopressor therapy, if you have pneumonia, a lot of patients with COVID ended up having atrial fibrillation. Pregnant patients sometimes can have like atrial fibrillation. But basically, if you, in that extreme stress period, you have AFib, that does increase the chances that you're going to have atrial fibrillation in the future. But we have decided that when you have atrial fibrillation in this acute stage, then maybe it's not really atrial fibrillation the way that we think it, which means that we will treat the atrial fibrillation. We might do anticoagulation for those patients in the acute phase, but it's not something that's going to follow them for the rest of their lives. Again, on X previously, when there was a lot of cardiovascular training happening, a lot of folks would say, hey, AFib is a metabolic and structural disease that is occasionally exacerbated with RVR by the acute medical problems. What does this mean? It basically means that when you see it, particularly in the when you have shock, then you don't necessarily have to treat the atrial fibrillation. Don't concern yourself with treating AFib. Instead, concern yourself with treating what is underlying. So when you have fever, anemia, hypoxia, hypovolemia, infection, inflammation, catecholamine surge, or myocardial injury or electrolyte imbalances, what does this do to your action potential? It actually decreases the action potential, making you more likely to have those increased electrical ectopic beats, which can come from the pulmonary veins. And that actually increases the chances of you having atrial fibrillation. So basically, it kind of causes an increase in your trigger, right? And so all those things, the structural changes that can happen as a result of, your sepsis, if you're in shock, that also increases your substrate. And so what that means is that for those patients, they're more likely to go into atrial fibrillation. There have been some studies that have been done following up patients who have atrial fibrillation with illness. And what they found is that the more you have some sort of precipitant, the more likely you will have recurrence of atrial fibrillation. A lot of it is considered to be as a result of acute infection. Cardiac surgery is also a risk factor. And then actually some CT surgeries can actually cause you to have AFib, recurrence. So if you look at a septic patient, you want to think to yourself, okay, is this acute or is this chronic, right? So is the atrial fibrillation considered to be new, or is it something that has happened over a period of time? And then for each of those, you want to look at rate and rhythm control. And if you want to, and you also want to look at stroke prophylaxis. Most of the time you're doing medical management with rate and rhythm control. A lot of times you're trying to prevent stroke. The left atrial appendage occlusion, you probably don't want to do it in this acute case, right? Stroke prophylaxis is necessary because you do have this increased risk for stroke up to 2.6% of individuals, particularly if they have a CHA2DS2-VASc score that's high. So you still want to give anticoagulation in those cases. And this actually made it into the guidelines where patients who have atrial fibrillation that were identified in the setting of stroke, basically you still have to be counseled about that risk. That's class 1. You do want to start oral anticoagulation. That was a 2A. And basically, for those patients who have critical illness, though, due to sepsis, anticoagulation during the critical illness was considered to be uncertain. So that's a 2B. So you might decide that you're going to anticoagulate the patients, but sometimes you don't. So if you have a patient with atrial fibrillation who has an acute illness, the first thing that you have to do is treat the underlying condition. So address if the patient is hypovolemic, anemic, in respiratory distress. If the patient is in shock, that's basically what you should be treating and what you should be concerning yourself with. Unless the patient doesn't have illness, let's say somebody who comes in with signs of shock and a fever, right, is very different from somebody who just comes in and has shock as a result of them being in atrial fibrillation, right? For the latter patient, you want to cardiovert immediately. For the former patient, you want to treat the disease and then you can cardiovert if you need to, right? When you're talking about cardioversion, you can either do an electrical cardioversion or a chemical cardioversion. And then towards the end, you want to kind of look at whether the patient needs rate control as well. Most of the time, it's usually taken care of by the cardioversion. Now, how about when we look at structural heart disease? There are a few things to concern yourself with. One of them is, hypertrophic cardiomyopathy. Those patients typically will have an increased risk for having AFib. And just like patients with mitral stenosis, if you have hypertrophic cardiomyopathy, whether it be your classic with basal hypertrophy, basal septal hypertrophy, or if it's like apical HOCM, those patients have an increased risk of atrial fibrillation. Those patients need to be on anticoagulation regardless of CHA2DS2-VASc score. Other thing to consider is that ablation is typically less successful. It doesn't mean that we don't do it because there's some patients who, you diagnose them early and you can basically delay the onset of atrial fibrillation because those patients who have structural heart disease, particularly HOCM, are actually very symptomatic when you look at their atrial fibrillation. And so taking them, giving them an ablation might actually be helpful, but you have to prepare them for the fact that it might not be as successful. Patients who have heart failure, Marouche did a study called Castle AF, and basically what they found was that patients who have heart failure, if you do a catheter ablation, those patients actually do really well, particularly if their ejection fraction is greater than 25%. So that is something definitely to think about. How about atrial fibrillation and thyroid disease? If the patient is hyperthyroid, then you really want to concentrate on rate control. Stroke prophylaxis is only necessary if the patient has, a CHA2DS2-VASc score that's high, but it's only necessary while the patient is being treated for hypothyroid. Once the patient has been treated, then you might actually not need the anticoagulation anymore. And that's because most of the time, those patients do not have any atrial fibrillation once you've taken care of their heart rhythm. So if you have an acute medical or surgical illness, you want to find out if there's a trigger. You look at the patient's risk factors. If they have, this is just a finite, like, hey, they've never had atrial fibrillation before. The AFib is just as a result of, their acute illness. Then basically what you want to do is treat those precipitants or triggers. You want to do rate control prior to you doing rhythm control a lot of times because that's complicated by, let's say somebody has sepsis. A lot of times they'll have liver disease, sometimes they'll have renal disease, and it limits your options. But don't shy away from also doing, rhythm control if you need to. And sometimes rhythm control really is the most effective way of rate control. You want to make sure you counsel them for the risk of recurrent atrial fibrillation. A lot of times they'll say that they haven't felt it. And so you actually want to see the patient very often for follow-up, do some monitoring, and try to decide or try to determine, is this, atrial fibrillation as a result of their illness, or is this going to be something that is as a result of their, it could it have been like the first time that they show up, but they actually have a history of paroxysmal atrial fibrillation? All right, now when to refer for ablation. So from long ago, there are folks who were much smarter than me who determined, how we could kind of treat atrial fibrillation and what we should do. Right now, what we do is mostly intravascular. There are different strategies that we can use. We can either make it really cold, or we can make it really hot, right? So for those patients for the cryo, you have here like a cryo ablation balloon where you put it around the pulmonary veins and you freeze. It is less successful only because cold doesn't produce as much of an through scar. And a lot of the time we can use it for patients who have paroxysmal atrial fibrillation, but it's less successful in patients who have, persistent AFib. Um, you have RF, where you do kind of this point by point ablation around the pulmonary veins, a little bit more successful. This is basically kind of the standard of care for atrial fibrillation at this point. And it has the best success rates on top of using amiodarone for treatment. And then there's also this, strategy called, which is new, called PFA, or electroporation. And this is basically a non-thermal technology where you're able to apply it to the tissue that is surrounding the heart, with the idea that it preserves the nerves, the vascular smooth muscle, and the esophagus, and you don't have that risk. One of the risks for this is an atrioesophageal fistula. You don't have that risk anymore. And it's kind of a one-shot ablation technique. They say it's one shot, but really it's more like 8 shots around the vein. But it ends up, it does have its own limitations. So one of the things is coronary artery spasm. This was something that was presented a few years ago, where they basically saw, the coronary artery spasmed a little bit. You had some ST elevation, so that can be a little bit scary. Otherwise, other things that can happen, sometimes with use of the pulse, you can actually disarm the heart and actually disarm all your electronics. There were a few occasions where, everything in the lab turned off because of that huge pulse of energy that you have to give, in which case, the patient was in asystole. They had to do CPR until the patient's heartbeat came back. It was kind of dramatic. And so now, what we do is we make sure that we have a temporary pacer when you're doing this. One of the more tragic things that can happen is the risk of renal failure because of the huge like blood. Basically, it's a period there where you can have I'm having a brain fart. But basically, it can cause you to have renal disease because of the destruction of the cells, therefore causing, I've lost the word, but pretty much you'll have kind of blood in the urine. And you end up having a situation where you end up maybe putting the patient at least temporarily on dialysis. So that can be a problem. It's still something that, has just come to commercial use in the US. They've been using it for a few years in Europe. We'll see what the future holds with regards to that technology and how it compares to RF. And then, of course, there's the surgical ablation where, somebody goes epicardially and actually ablates from the epicardium. We do our endocardial ablation. And then you find that because of that, you have like a whole scar through the heart. And that can be very helpful, reducing the chance that you would have atrial flutter. If you do the epicardial ablation alone, it's not unusual for you to have atypical atrial flutter following. So those are things that we have to consider for those patients. A lot of times, you do this procedure, the surgical ablation, you do that during another surgery. So it's not unusual for somebody to say, hey, I have a history of AFib, and then the surgeon does an AF ablation in addition to doing like a valve surgery or doing like bypass surgery because they're already there. There are rare cases where you will just do the cardiovascular surgery because of the AFib ablation, but that's a little bit rarer. So, with regards to our patient, This is basically what we did, where we ablated around the pulmonary veins. And this is basically looking at the heart from the back side. So this is the posterior wall. These are the pulmonary veins. This on the right side, on the left side. And we just basically formed like a little scar. And that's why you can kind of see here being red. So whereas you had electrical activity here previously, now you don't have any electrical activity, and the patient ended up doing well. If the patient had a device, this is basically what the device shows. So over here, it was 24/7. Here was probably like a brief cardioversion, came back. And then with doing the ablation, you have no atrial fibrillation anymore. And this is the patient's EKG. All right. So I hope I've answered a few of your questions. I know that a lot of or some of what I talked about is not available, and we're hoping that we can make it available. And in the future, what we're basically going to be doing is just trying to collect data to see exactly how much atrial fibrillation we have. Who are the patients that are presenting with atrial fibrillation? What kind of symptoms do they have? I think that with collection of data, we'd be able to determine what is helpful to serve the communities in which we are. And with that, thank you.
Fantastic talk. I really appreciate you going through all that. Sorry I couldn't really, help with the hematuria question, but one thing I don't know, like you said a lot of interesting and relevant things, but the one that really just stuck in my mind is elephants have a higher degree of AFib.
Oh yeah, they're like almost always a AFib.
Now here's the thing. I looked that up. I did some digging, and it's all based on elephants in captivity, right? For the most part.
Yes. I mean, yeah,
So, so I mean, we can't say that
we
maybe
don't know.
atrial
I guess we
fibrillation.
don't know. That is true.
So maybe like it's society in general that causes AFib. These are the questions that we need to get to.
That is true. I'm just having a vision in my mind trying to run after an elephant, put some EKG leads. Like,
Put some
hold
EKG
on,
patches on it.
hold on, wait a second. Not trying to do anything. Just
No,
let me get this EKG real quick.
just the
That
domesticated ones with the Holter monitor on. Perfect. Do we have any other questions from the chat at all? Elephant related or AFib?
oh,
We're happy to. I think we had some really good questions early on. I really appreciate you answering those as we went. And then if there's anything more to come, reach out to us on the side. You can also just comment. We're going to put this all on YouTube. I remind everyone that, we're going to be having these talks weekly. So please join us if you can. They are all available on YouTube, but it's so much more fun if you join us and participate live, just because we have better engagement and we can really understand what your questions are and how we can answer them best. So thank you very much, Dr. Caro, for going through that. That was really fun and enlightening. And I think that we all learned a little bit more about atrial fibrillation. And
um,
yeah, if there's no more questions, do you have any
and I
final
just
thoughts
want
for
to
us?
mention, that again, atrial fibrillation is one of those things where it's like high blood pressure, right? Where the effect from atrial fibrillation, you don't see it immediately. It's one of those things that you kind of see far away from onset, but the effects are there, particularly when you consider heart failure and stroke. Those are huge, particularly with stroke. This is one of those things where prevention is definitely better than cure. And so I urge you to talk to, the physicians in your community. It should be one of those things that we recognize sooner rather than later.
Fantastic. I think that's great. That's a great takeaway from there. So see you all next week. I think it is Fania, Dr. Theophany Mela will be presenting on SVT, but really appreciate you all taking the time with us this Sunday, and we'll see you soon.
All right. Take care. Bye.
Thanks.